hypofractionation is when you use larger daily doses of radiotherapy to treat and ultimately complete the entire duration of treatment in a shorter amount of time. And, you know, as a background, everyone knows that the world, the globe in general, is going through some sort of resource crisis shortage at this point, and it covers, you know, economy, infrastructure, health resources, and human resource as well. And there's nowhere this is more pronounced than in the African continent. So, you know, really being able to allocate our resources effectively and expediently to deliver treatment has become not just good, but essential. So thank you for joining, and you know, we look forward to learning from the speakers how to implement hypofractionation in our different practices. So our first speaker today is Dr. Na Adokoye, joining Ghana this morning, and she's going to be talking about fast forward in the context of the African continent. So Dr. Na, over to you, and thank you everyone again. So just as housekeeping, if you're not speaking, please remember to stay muted. Let's hold all questions till the end. There's going to be a panel session at the end with all the speakers, and all the questions and answers be done at that time. But in the meantime, while the sessions are going on, please feel welcome to post your questions in the chat, and we will take all of them at the end of all the presentations. And please feel free to include your country in your name so that we all see where everyone is joining from. So I'm Adida Joseph from Nigeria, and I'm going to change my name now to reflect that. Thank you all.
Hi, everybody. Good afternoon. My name is Na Adokoye. I'm a clinical oncologist from Kolebu, Accra. So our discussion is on the fast forward trial, the hypofractionated radiotherapy schedule for breast cancer. So over the period, what we've done is use conventional radiotherapy. And it's useful because of the differential response of tumor, which is usually rapidly responding compared to late responding tissues, which have a lower alpha beta ratio. Now, the reason why that has been useful is just because of the differential response. But over the years, we found that certain cancers, including breast and prostate cancer, actually have alpha beta ratios that are much lower, close to that of normal tissue. And so it makes sense to use hypofractionation, right, to improve tumor kill. But what's important is that while we do that, we need to protect normal tissue as well. And with the advent of different kinds of radiotherapy equipment and techniques, that's possible now. And so that's something that we are exploring. Over the past 10 years, I'm sure you would have noticed quite a number of hypofractionation trials for breast cancer. There's the START trials, the Dutch trial, the Canadian trial, and even the Chinese trial. And for all of these, 2.7 grain 16 fractions or 15 fractions is the standard. However, it's obvious that the 16 or 15 days does not represent the whole limits of hypofractionation. In fact, we can have much bigger doses over much shorter times and improve outcomes all the same. So for the fast forward trial, most of the levels of test doses were based on the START trials and the FAST trial. So the 40 grain 15 fractions from the START-B trial and the 27 grain in 5 fractions from the FAST trial. The only thing I need us to note is that in the FAST trial, the dose per fraction over 5 was delivered weekly over 5 weeks. But in the fast forward trial, the 5 fractions were given all within a week. And also from the fast trial, it was obvious that the alpha beta ratio of 3 gray matches the normal tissue effects at 27 gray. The decision to add the 26 gray in 5 fractions was mainly to cater for time, which was not available when you compare to the FAST trial. So nearly 100 centers in the UK recruited patients for this trial from November 2011 to June 2014. An ethical approval was sought for all the local centers and also nationally. The protocol was not developed by any sponsor, it was by a group of clinicians and patient advocates. It searched to explore the further we can take hypofractionation, and it was to establish if there was non-inferiority for safety and efficacy for 3 doses, 40 gray in 15 fractions, 26 gray in 27 fractions, pardon me, 26 gray in 5 fractions, and 27 gray in 5 fractions, all delivered in a week. Using a bespoke randomization, patients were randomized in a 1:1:1 fashion to the individual arms of the trial. The treatment was unmasked, obviously because of the different fractionations. If a patient needed a sequential boost, it had to be announced prior to the randomization. And during the study, endocrine and trastuzumab were allowed concurrent with radiotherapy, but not chemotherapy. There were a number of sub-studies as well. There was the acute toxicity study, the photographic assessment of late adverse effects study, and then the patient-reported outcome study. Then subsequently, as the trial went on, another sub-study was opened that looked at the use of the same hypofractionation schedules for the treatment of patients who required axillary and supraclav lymph node irradiation if they had sentinel lymph node biopsy, or for those who require supraclav irradiation only after axillary lymph node dissection. I want to talk a little bit about the radiotherapy because, like I said, when you do hypofractionation, you must be concerned about what the late tissue effects would be. So for all the patients, 3D conformal radiotherapy was used. CTs were taken at 5 millimeter slices, and several energies were allowed, 6 MV, 10 MV, and even if there was a need for a mix, that was allowed as well. The surgeons were encouraged to use either titanium or gold clips so that the tumor cavity could be easily identified. Contours were drawn for the breast conserving surgery from 5 millimeters below the skin to the pectoralis fascia, and then for chest wall, also from the skin to the pectoralis fascia. The muscle and the ribs were not included. Obviously, the patients were early stage. And then a pair of opposing tangential fields was used. Now, for the patients who received 5 gray fractions, daily verification was required, and any deviations had to be corrected before the radiotherapy was delivered. There were a few guidelines for the treatment. More than 90% of the PTB had to receive 95% of the prescribed dose. Less than 5% of the PTB had to receive 105, and the global maximum was less than 110%. The organ at risk constraints for the heart and the lung are in the study, and you can have a look. The sample size was 4,000, and the reason for this was that it allowed for an 80% power to determine an absolute non-inferiority margin of 1.6 for in-breast tumor recurrence at 5 years. The study also assumed a 2% 5-year in-breast tumor relapse incidence for the patients who received 40 gray. All the patients were equally matched within the trial for demographic, clinical, and pathologic effects. And then an allowance of 10% was given for patients who would be lost to follow-up or patients who would die. For the sub-studies, the power of the trial was also 80%, and this was to detect an 8% difference in the prevalence of late normal tissue effects for the 5 gray schedules. They also allowed a 10% loss to follow up. And it's also assumed a 5-year mild to marked change in photographic appearance of the breast, as was in the case for the START-B trial. So this is the consult table for the study. And after all the exclusions, in the end, 1,218 patients were in the arm that received the 40 to 15 fractions, 1,231 patients in the 27 group in 5 fractions, and then 1,232 for the patients who received 26 gray in 5 fractions. So the results for ipsilateral breast relapse, after a median follow-up of 71.5 months, the ipsilateral breast tumor relapse was recorded in 78 patients. And as you can see in the table I have below, the upper limit of the confidence was all below 1.6. And that established non-inferiority for the 2 experimental arms. That's 27 in 5 fractions, and then 26 in 5 fractions, all delivered within a week. This is the Kaplan-Meier curve that shows the ipsilateral breast tumor relapse rate, and you can see the recurrence rate was very low. They were all below 3% at 5 years, and even beyond 5 years. From the study, an unadjusted alpha beta ratio for ipsilateral tumor recurrence was 3.7. And the 2 gray equivalent dose estimates for the 40 gray in 16 fractions was 44.7 gray. For the 27 gray in 5 fractions was 43.1 gray. And that's for the 26 in 15 fractions was 40.6 gray. When adjustments were made for the various risk groups, with the low risk being people who were older than 60 years with ER/PR positive disease and grade 1, grade 2 tumor, there was no difference in the alpha beta ratio estimation. And the same was true even when heterostatus was used. For relapse, both local, regional, and distant, there was no difference in the 2 arms. No subgroup analysis were done, unfortunately, because the numbers of endpoint events were very few. And as you can see from the p-value, there's no statistically significant difference in the local relapse rate, in the distant relapse rate for any breast cancer event and for all-cause mortality. You can see that the p-values are all below 0.05. Now, for the different arms, there was no difference in invasive contralateral breast cancer incidence, and there was no difference in non-breast secondary primaries as well. For the patients who had died, which were only 7% of the study population, 3.7 of them died from breast cancer, 3.1 from other causes, and then measly 0.3% died from unknown causes, but they didn't have any evidence of disease relapse. There were 27 cardiac-related deaths, and that's important because of the hypofractionation. But majority of these patients either had cardiac disease prior to randomization or they were smokers. For the clinical assessment of normal tissue effects, an annual clinical assessment was done for at least 97% of the patients. And for moderate to mild clinician assessed normal tissue effects for breast and chest wall at 5 years, for those patients who had 40 gray in 16 fractions, 9.9% of them noticed this, 15.4 for those with 27 gray in 5 fractions, and 11.9, pardon me, for the 26 gray group. There was a significant difference between the 40 gray and the 27 gray in 5 fractions, the p-value of 0.003. but no statistically significant difference was seen between 40 gray and 26 gray. And breast shrinkage was the commonest marked effect at 5 years. For patients' reported outcomes, the number of questionnaires that were returned decreased over the study period. That's not too surprising. From 99.6 at baseline to 84% at 5 years. And moderate or marked changes were reported as follows: 32.4% for 40 gray, 35.9% for 27 gray, and 31.7% for 26 gray. Remember, it was estimated that it was supposed to be around 35% for the comparative arm. Now, a change in appearance was the commonest reported outcome by the patients at 5 years. And the 26 gray schedule appeared to have a lower risk of change in breast appearance, although at 5 years, there was no statistically significant difference in the patient's reported outcomes. For photographic outcomes, of course, the number of photographs that were returned reduced throughout the study period from a baseline of 94.1% to 79.7% at 2 and 5 years. Using a 2 and 5 year modeling photographic assessments together, it showed that the 27 gray had a significantly increased mild to marked changes in breast appearance. But there was no, when you compared it to the 40 gray one, but there was no difference when it was compared to the 26 gray. And in fact, the 26 gray had a significantly lower risk of photographic breast change appearance with the p-value of 0.006. So that was statistically significant. Now, basically what the fast-forward trial demonstrated was that for in-breast tumor recurrence, 27 gray in 5 fractions, or 26 gray in 5 fractions delivered over 1 week, compared favorably with 40 gray in 15 fractions at 5 years. Most of the patients were early stage, however, and so had just local excision of the disease and sentinel lymph node dissection. Normal tissue effects at 5 years were similar between the 26 gray in 5 fractions and the 40 in 15 fractions. But it's obvious that as you follow the patients up for longer, the risk of normal tissue effects will increase. And this was shown in the FAST trial. However, the good news is that the relative difference over time is usually insignificant. So in the STAR trial, for example, breast shrinkage was 11.4% at 5 years, but by 10 years, it had increased to 26.2%. The fast-forward trial can actually be applied to different prognostic groups. And the reason is because there were very low in breast tumor recurrences. A meta-analysis that was done on the STAR trials with nearly 6,000 patients showed no inconsistency of effect for normal tissue effects or recurrence risk across prognostic or treatment groups. So even if you had patients who had grade 3 disease or HER2 positive disease, you could still use the fast-forward fractionation. The absence of a difference in the in-breast tumor recurrence just reflects how shallow the dose response curve is for subclinical disease. But when it comes to normal tissue effects, the graph is much steeper. And that's the reason why there was a statistically and clinically significant difference in the event rates between the 26 gray in 5 fractions and the 27 gray in 5 fractions. You think that the dose is very small, but that makes a difference. And the other thing is that in the FAST trial, because the dose in the upwards of 5 gray was given once a week, it allowed for patients to recover. So there was time for recovery, which is not the case in the fast-forward trial. The alpha-beta ratio that was estimated is similar to that was estimated from other trials like the START pilot and the START-A trials. However, for late normal tissue effect, that from the fast-forward trial appears to be much closer to 2 gray compared to 3 gray, which was found in the other START trials. It appears that the 5 fraction regimen is also relevant for partial breast radiotherapy. So for patients who don't want whole breast irradiation therapy, the fast-forward schedule will work for them as well. But beyond its safety and effectiveness, and we've seen that it is non-inferior to the 40 gray in 15 fraction, the other advantages of the fast-forward schedule is that it's convenient, it's less expensive for the patient. You can imagine 3 weeks of radiotherapy to now 1 week of radiotherapy. That would make such a big difference. And it's also less expensive for the healthcare services. More patients can be seen over a short period. It is also likely to be safe for patients who are receiving regional radiotherapy. And like I said, a sub-study was opened during the study to look at using the hypofractionation schedules for those who required axillary radiotherapy as well as supraclav radiotherapy. Although the heart is sensitive to a large total dose of radiation, cardiac effects in the fast-forward trials were very few, just 27 of them, like I stated earlier. And so no meaningful analysis could be made from that. It was also not possible to do any subgroup analysis because the events were so low and you needed a higher power for that to happen, about 6,000 patients, for you to be able to make meaningful subgroup analysis. And that was not the case in this trial. So in conclusion, the 5-year in breast tumor recurrence incidence after 27 gray in 5 fractions or 26 gray in 5 fractions for adjuvant radiotherapy is non-inferior to the standard 3-week regimen. 26 gray dose level is similar to 40 gray in 15 fractions in terms of patients assessed normal tissue effects, clinician assessed normal tissue effects, and photographic change in appearance. Also, the 26 gray in 5 fractions is similar in normal tissue effects. The effect from the 26 in 5 fractions will be similar to the normal tissue effects that would be expected if you gave 46 gray in 2 gray daily fractions or 48 gray in 2 daily fractions as well. The fast-forward trial results are consistent with earlier hypofractionation trials with similar alpha-beta ratio for tumor recurrence as well as for normal tissue toxicity. Basically, the study supports the adoption of 26 gray in 5 fractions as a new standard for women who are receiving radiotherapy after operable breast cancer. The 27 in 5 fractions is associated with a few toxicities in the late, for new toxicities for normal tissue effects. And the other good news is that the fast-forward regimen can be used in patients who receive partial radiotherapy, as well as for those who receive whole breast radiotherapy. Thank you very much.
Thank you very much. That was a very succinct and nice way to summarize these trials and talk about, hyperfractionated regimens for breast cancer. I do know there's going to be a few questions about its applicability in our context with more advanced disease, sometimes inadequate axillary staging and co. But as discussed earlier, please post your questions in the chat, and then we will take all questions and answers at the end, the panel session with all the speakers. So very quickly, we're going to move on to Professor Twalib Ngoma, who is joining us, clinical oncologist, clinical radiation oncologist from Tanzania. Prof. Twalib, we're ready for you. Thank you.
Okay, where can we do? Start. Hello, do you hear me? Hello?
Yes, Prof, we can hear you very clearly.
Thank you, and good afternoon, everybody.
Good afternoon.
What I'm going to share with you today is about the hypofractionation in the context of sub-Saharan Africa.
Prof. Ngoma, we're losing you a little bit. So maybe you want to turn your video off, and that might help with the audio. We can't hear you anymore at all at this point. Can other people hear Prof? I think I'm the only one.
No, we can't hear him.
No, we can't.
You can't hear me now? Maybe
Yes,
I
we
should.
can hear you now. We can hear you now.
Okay.
Yes.
So my topic is hypofractionation. Is it a solution for prostate cancer in Africa? We look at the prostate cancer because it's the commonest cancer in males in our region. And radiotherapy has a big role in the management of prostate cancer. At the same time, we know very well that radiotherapy facilities are not adequate. However, there is evidence from studies which were done outside Africa that hypofractionated regimes could be able to solve the problem of lack of access to radiotherapy. I will cite a few selected references, and you can get these whenever you have, when I finish my presentation, because I have cited them fully. But there are many, many articles about hypofractionated radiotherapy and its use. We also have guidelines, ASCO guidelines. And we have done also some work in Africa to see if there's going to be any saving in terms of cost if we adopted hypofractionation. So based on the evidence from clinical trials done outside Africa, our team developed an interest to look at the feasibility of adopting hypofractionation to start with for prostate cancer in Africa. We were not only motivated by the publications of studies that were done elsewhere, but also the local study looking at the costs of conventional radiotherapy versus hypofractionated radiotherapy, the huge cost savings that were realized through this study made us to ask ourselves, is it possible to get local evidence from Africa, that would convince our policymakers, would convince our professionals to have hypofractionation in our treatment guidelines. So the study that we did, and most of the team members in this Hypo-Africa prostate cancer, it is
Prof.
also cited in my slide.
Prof, your slide
Which
has
says, can the
I wasn't
you
sure.
can't see my slides anymore?
They're not changing.
They're not changing. Oh.
Yes.
But I'm changing them here.
Maybe you can reshare. You can stop sharing and then share again, and maybe that would help.
Yeah.
Okay. There we go. Thank you.
So I was saying what motivated us most was the local study we did in oncology centers in Africa, which showed that the cost per course of conventional and hypofractionated regimens were $232 and $1,339 for breast cancer. You can very well see that with the projected potential maximum cost savings for hypofractionation implementation would be $1.1 billion for breast. For us in low and middle income countries, where we have a lot of competing priorities, but still at the same time, we have need to treat our patients with radiotherapy. It is studies like this that can give us evidence, can raise questions among us to see how these already evidence-based studies which have been done elsewhere could be adopted in our settings in the sub-Saharan Africa. So when we met as a team and we were brainstorming about what we can do in hypofractionation so that it could be adopted in the local context. I remember during the meetings, there were people who were saying that it's not easy to do clinical studies in Africa because the infrastructure is not there to do the studies. But before that, we had done another study, really, to look at Africa. And we also looked at the research capacities. From that study, quite a number of centers, oncology centers in Africa, showed that they could conduct clinical trials and that they were doing clinical trials in other fields, not in cancer. So we were convinced that we can also do a clinical trial in African settings. We also, after brainstorming, thought that adopting hypofractionated regimens as a standard treatment for breast and prostate cancers would result in substantial savings and increase radiotherapy access in Africa without even incurring more costs in terms of buying new equipment. That we decided to form a team among us, and we called that Hypo Africa team, to do a hypofractionation study on prostate cancer. We were very lucky that among our team, Professor Luca Nkrokai or Erasmus, he was involved in another big study of hypofractionation. And he was a good resource for us while we were planning what to do. So he became the project leader for what I'm going to tell you we did or we are doing. I will not give you a lot of data because we just started the recruiting patients and we have not even finished recruiting the patients. unlike the previous speaker had done the session, we had Professor William Gua of Johns Hopkins University. At that time, he was in Harvard, Dana-Farber, but after that, he moved on. And for the investigators in Sub-Saharan Africa, the moderator today, Adedayo Joseph, from Lagos, Nigeria, was one of the principal investigators. I myself from Dar es Salaam, Tanzania, one of the principal investigators, and Abba Malum from University of KwaZulu-Natal was the third principal investigator from South Africa. He joined us a little bit later, but before we even started recruiting. We were very lucky to get funding from BioVentures for Global Health. And BioVentures for Global Health have not only funded this trial, they have facilitated the conduct of this trial. And I would like to take this opportunity to thank them for funding and facilitating the implementation of this research. So what have we done so far? As I started telling you that out of the need from evidence done elsewhere, we thought we should do something that would be useful in the context of Sub-Saharan Africa. So in October 2020, we had our first Zoom meeting to start discussing about the study, and a decision to develop the study protocol was made there. The aim of the study, and it's very important to realize to know what we were aiming at, because studies are done to answer specific research questions. So we wanted to assess the feasibility of applying hypofractionated radiotherapy for localized prostate cancer in Sub-Saharan Africa. In other words, is it feasible? Because you could have evidence-based data that works very well in Western settings, but would not work in different settings, because the infrastructure available is different, the human resources are different, the financial resources are different, etc., etc. So we wanted to see that we have no doubt that hypofractionation works, but is it possible for it to work as well in Sub-Saharan Africa? With the experience of Luca in his previous studies, we managed to develop a protocol for our study in May 2021. And then we started working on ethical clearances, institutional review boards in the 3 centers. Once that was done, last year in mid-2022, we started patient recruitment. At the same time, we started having weekly meetings to discuss quality assurance data and data issues. This has been going on every week, whether it rains or it doesn't rain or it's day, but meetings have been there to discuss quality assurance issues. And these meetings have been very, very helpful in improving on what we are doing. As I'm talking to you now, because we have recruited quite a number of patients, although we have not completed the recruitment, we have some preliminary analysis of the data. And we are preparing an abstract to be presented to the AOTIC meeting in November this year. About the study. This is a multi-center, it's prospective observational study, which is being conducted in 3 sites in Tanzania, Nigeria, and South Africa. With the help of statisticians, to do what we wanted to do, the calculated sample size was 182 patients. So you can see it's not a very big sample size. I'm not talking about 4,000 patients. But even then, because we are looking at early localized prostate cancer in our centers, most of the patients who present for treatment in our centers have locally advanced prostate cancer and metastatic disease. We wanted to study patients with localized prostate cancer. So we wanted to be realistic that we could recruit these patients in 1 year. And 182 patients was the figure that we agreed we were going to recruit. The patients that we were going to recruit, the inclusion criteria was they should have histologically confirmed and they should have localized disease and also should have a low or intermediate high risk. It could be NAT, it could be NAPSA, it could be N-Gleason, but they should be NO and MO. And to be sure they are NO and MO, that should be based on CT scan or MRI and bone scans, scintigraphy, or PET, PSMA scans, if and when available. Like any study, whoever is recruited in the study, they should be willing to provide informed consent. And also, because we are aware of problems with follow-up of patients in our region, the patients should be willing to participate in post-treatment follow-up at 3 months, at 12 months, and 24 months post-treatment. And we also agreed that we do the follow-up for 5 years so that we could be able to present data that has long follow-up. The exclusion criteria for our study was radiological evidence of pelvic nodal disease from CT scan or other investigations, presence of distant metastasis, patients who had elective lymph node irradiation or who have inflammatory bowel disease or previous pelvic radiotherapy or previous prostatectomy, hip prosthesis, or if for any reason whatsoever, even without telling us why, they are unwilling to participate or they will not make it for follow-up. These would be excluded from the study. For the radiotherapy treatment, because all the centers had said that they had linear accelerators, we decided that patients would be treated with intensity modulated radiotherapy or VMAT. We insisted that quality assurance should be done and that toxicity assessment using the RTOG, EORTC, or CTCAE criteria should be done as per protocol during treatment, upon completion of radiotherapy, so that we could also record late toxicities. On treatment, evaluation for toxicity should be done weekly, and this was the practice in all the 3 centers. And after patients had completed treatment, there would be an end of treatment evaluation to record also the side effects at that time. Patients would be followed up for up to 5 years. So what has happened up to now? As of today, 151 patients with histologically confirmed localized non-metastatic prostate cancer have so far been enrolled. And these patients, they would either get, if they are low or intermediate risk, 60 gray or 62 gray if they're high risk patients. Looking at this data from the 150, it's like 50-50. There are those who got 60 gray and those who get 62 gray. When you analyze the 151 patients enrolled up to date, 88 have finished their treatment, and 60 have completed their 3 months post-radiotherapy assessment. %, that is 64% of patients received the 60 gray, and 36, which is 32 patients, received the 62 gray. 50 were treated with the intensity modulated radiotherapy, and the other 50, about 50, mostly from the South Africa Center, was the VMAT. Regarding toxicity, none of the 60% experienced grade 2 or worse grade 1 GI or GU toxicities according to the criteria that we were using to assess the patients. In other words, even from experience, patients who were getting hypofractionated regimen experience early side effects more than those radiotherapy. While doing this study, there are a lot of lessons that we learn. And some of these we might call challenges, and some of these we may look at a challenge. If you look very careful, you see opportunities. During our Saturday meetings, since we started, we have been dealing with hypofractionation. And in a study setup, quality assurance is a must. So at the beginning of the study, a question was asked of the in the 3 centers. How do they plan the treatment? How do they do quality assurance of the machines? What facilities are available? It's assistance, because very fortunately, our team has trained to help and to assure that quality assurance can even be done remotely using the technology that is now available. So from these questions,
Prof, are you there? Okay, so I think we lost Prof. Ngoma there for a minute. But I do think it was at the end of his, oh, my video is off. I do think it was at the end of his presentation. I'm trying to see, Prof. Ngoma, are you still there? I don't see him. 1 second, please. Okay, so we've lost Prof. Ngoma there for a little bit, but I do think he was at the end of his presentation, and we'll probably have time to catch up again at the panel session. As I said already, if you have any questions, please put them in the chat, and we'll try to answer them at the panel session and then also in the chat as we go along. We welcome now Dr. Stephen Avery to take the medical physics session, and is joining us from UPenn Medicine. Dr. Avery, thank you so much.
Yeah, thank you. Thank you for inviting me. I'm glad to be here.
We don't hear you very clearly.
How about now? I just turned my mic up.
Yes, it's not very clear yet.
Clear?
It's in and out a little bit. Or is it just me?
Okay. Maybe, sure, maybe everyone, can anyone confirm that?
Yes, I think we can hear you now.
Okay. Can you see my screen?
Not yet, but we can see you.
Okay. Maybe it's a slight delay. So let me know if it pops up. It says I'm sharing.
Well, I don't see. Does anyone see Dr. Avery's screen?
No, not yet.
Not yet.
stop and start
Not
Maybe-
yet.
And reshare.
it. Okay, now I'm resharing. As your share screen is loading, so maybe it will take a time.
Still no.
Yeah, you're still telling me it's loading. I could email it to you that faster. It's going to take time. I'm in a different building in the hospital. The network might be a little lower in this building.
Okay, so do you want to email it and then we'll share it for you, and then maybe turn off your video. Maybe that might help.
Yeah, let me do that. It's still telling me it's loading.
Mm-hmm. You can see it's starting to share, but not quite yet.
Okay. Email it to you, that might be faster.
Mm-hmm. I'm gonna.
But you said it is starting to come up, which is very slow.
Steven, do you want to send it to me and then I'll share it?
Yeah, I'm saving that. I'll send it to you.
Dr. Joseph, should we have another presentation while we wait?
Okay, so can we do that? I do know that Dr. Avery has a tight schedule today, so I wanted him to be able to finish his session. But if that's okay with you, can we take another session and then come back to you right after?
Okay, yeah, we can do that. We can do that.
So we can take Rohini Bhatia from the US to talk to us now about the application in cervical cancer. Rohini, are you ready?
Yes,
Okay, perfect. Thank you so much.
of course. Let me just share my screen.
I
Come in.
All right, can you guys see that okay?
Yes, we can.
Wonderful. Well, thank you all so much for the opportunity to talk today. We're going to be discussing the use of hypofractionation for palliative radiation in cervical cancer. And these are some of the wonderful people who've worked with this, and a special thanks to Dr. Grover for allowing me to work on this project. Okay, so we know that cervical cancer has a high mortality among women in Africa. Some of this is due to the prevalence of HIV in the region, and also with low vaccination and limited early detection programs. And they often present with locally advanced disease. So I'm sure all of you see patients who are very symptomatic when they present, right? With vaginal bleeding, discharge, pain, and we're trying to think about the best way to help them. One of the issues, and this is a wonderful study done by Nadella and other authors, is that transport to and from radiation facilities can cause delays, breaks, and low adherence to treatment schedules. So this is in sub-Saharan Africa, it's a heat map of travel time. So the areas in red are where it takes patients over a day to get to a radiation facility clinic. And the areas that are in blue is where it takes about an hour. So you see that the centers are really concentrated around, the southern part of the region. So knowing this, we know that it's difficult for patients to access radiation. For patients with poor performance status and symptomatic disease, this is even more amplified. And you see patients with poor performance status and bleeding tumors. How are they going to travel a full day in order to get radiation? And how are they going to do that on a daily basis? So can we provide a better schedule for these patients that have less visits to the hospital? And so there have been studies that looked at this. So this is a table of different fractionation regimens for advanced cervical cancer and for treatment of symptomatic disease. So the first one is 10 gray in 1 fraction monthly for 3 months, so 3 fractions. And studies have shown that there's about a 47% compliance in low and middle income countries, and that it's used either in 2D or 3D treatment. And these are some of the symptom control rates. So bleeding by the 3rd fraction is usually 100% controlled, and about 41% controlled pain in the 2nd fraction. These are other types of treatment regimens, and I would be curious to hear from all of you of what you use. One of these is 3.7 gray BID in 4 fractions, 2 to 4 weeks for 3 courses. 4.5 gray BID for 4 weeks. 4 to 5 gray in 5 fractions, or 3 gray in 10 fractions. And you can see that one of the issues with the 3 gray or the 10 gray in 3 fractions is this late toxicity rate. And we'll talk a little bit about how this may be not exactly what we're seeing in clinic and how this relates to picking particular patients for this fractionation. So has 10 gray been considered before? Well, yeah, if we look back at the literature, one of the first reports was back in the early 1980s, and it was 27 patients with advanced or widely metastatic cervical cancer. The radiation was done in fields that included L5 superiorly to the lower border of the obturator foramen, and the dose to midplane was 10 gray. And the median survival of all patients was about 7 months. All of the patients had cessation of their vaginal bleeding and a relief of pain, and 9 of their patients actually had a complete response of disease. There was 1 patient with a rectovaginal fistula, 1 with bowel obstruction, and 1 with rectal bleeding, and 3 who could not complete the full course of 30 gray radiation. So again, very small numbers, 27 patients, but really our first indication that this was a good idea. Also in the 80s, we had a little bit more patients in this study, 42 patients, and a very similar type of treatment, 10 gray, repeated once or twice at monthly intervals. Less cessation of bleeding here, but still seeing some complete tumor response, and 5 serious treatment complications. 4 of these were occurring 10 months after treatment. So the recommendation from these authors were that this is an effective means if the patient has a life expectancy of less than a year. That if patients who had a longer life expectancy, they may be at risk for recurrence and for treatment-related complications. Well, have we done anything more recently? And there was a study out of Tata Memorial in 2005 where they looked at treating 10 gray per fraction in 3 monthly fractions. But the difference was that if a patient received complete response after the 2nd fraction, those patients were treated with intracavitary brachytherapy. Their field size is a little bit bigger, 15 by 15 centimeters and a depth of 8 centimeters. And you can see the compliance of patients here. So 100% of patients got the first monthly dose, 61% of patients got the 2nd monthly dose, and 33% of patients got the 3rd monthly dose. This shows that 10 gray, and then on the 3rd fraction, someone had intracavitary brachytherapy, or 10 gray, and then the 2nd fraction with intracavitary brachytherapy. Bleeding response was very good by the 3rd fraction, and then pain response was 41% by the 2nd fraction. There was limited data on late toxicities in this cohort, but we see from the acute data and acute toxicities that it was mostly grade 1 to 2 toxicity. 3 patients, so 3% of patients, developed grade 3 diarrhea after the 2nd fraction. So what do we know? Well, we know that 10 gray by 3 monthly fractions has been utilized among low and middle income countries in Africa. And it is especially used for patients with poor performance status and advanced disease that is incurable. And it could be very helpful in centers with resource constraints and long radiotherapy waiting lists to ease the burden of disease. What we don't know is the % of patients able to complete all the fractions. What are the associated toxicities, especially now with better image guidance, and what is the impact on quality of life of these patients? So there's a study that's designed, which is a multi-site prospective observational cohort study to characterize the 10x3 palliative external beam regimen. The first aim of this was really to look at the efficacy of this palliative regimen in controlling cancer-related pelvic symptoms after each fraction. We want to look at the frequency of complete or partial bleeding cessation, the rate of complete or partial pain relief, and the rate of complete or partial relief of vaginal discharge. We also want to determine the feasibility of delivering these 3 palliative fractions. What is the compliance rate among patients? And also to understand what the indications and radiotherapy techniques of the participating centers were. So this is an example of what the 2D treatment plan for this study looks like. We use parallel opposed fields and 10 gray prescribed to midplane. The superior border is around L4, L5, inferior border obturator foramen or 3 centimeters below the lowest vaginal extent of the tumor. And then the lateral border is really 2 centimeters from the pelvic brim. 3D conformal therapy was also allowed on this treatment protocol. And we did 4-field box, 10 gray to the isocenter. The APPA was similar to what you saw with the 2D, and then the lateral fields were L4, L5, posteriorly, the posterior aspect of the sacrum, anteriorly 2 centimeters anterior to the vertebral bodies and splitting the symphysis, and the inferior field, bottom of the obturator foramen. And this just shows you what it looks like from the lateral view with blocks in place. Again, this shows you from an AP view of with blocks in place of what it looks like, and really trying to block out those superior corners to protect from bowel loops and the inferior corners to protect from femoral head. This is an example of one of the plans from Ethiopia. And this is an example of the 3D conformal 4-field box. So what have we seen so far? So we have 54 patients with cervical cancer were enrolled in Ethiopia. Stage 4 disease was present in most patients, over 3/4. The median age was 49.5 years, with a range of 30 to 81 years. The performance status, most had a performance status of an ECOG of 2, so half patients had that, with 16% with ECOG of 3. The most common indication for palliative treatment was renal function hydronephrosis based on our data. I think this is based on a lot of the creatinine in the labs that we have for the patients, but bleeding and vaginal discharge were also prevalent in high numbers. In the first 10 gray fraction that was delivered, most of them were delivered with the 2D plan with cobalt-60, and about 1/4 of patients had it delivered with the 3D plan with the 4-field box and 6-ME. So far, 38 out of 54 patients have received their second fraction of radiation. This is an ongoing study, and we're hoping to start the study in Botswana as well. And what we really want to understand is how will this work in other contexts? And are we capturing the long-term toxicity? One of the biggest challenges of this protocol is being able to follow up with patients. These are patients with poor performance status, and sometimes they may not come back for their second treatment. And if they don't come back, we want to understand why. Is it because of transportation issues? Is it because they are feeling better and don't feel the need to? Is it because they passed away because of their disease? Or is it because of a toxicity that we aren't capturing? And this is really, the crux of this study and why it's so important, because this is being used pretty widely right now. And what is the best patient selection criteria? What performance status of patients? What types of symptoms can this control? And really, are we helping our patients, which is the ultimate question. So thank you so much to our patients, to our collaborators, to our clinical team, and to our mentors for helping us with this. And I'm excited to hear about all of your experience and any questions that you have. Thank you.
Thank you very much, Rohini. That was very nicely summarized for everyone. And I know there's going to be some interesting questions. I have a couple myself. Just before we come back to Dr. Avery, I think we should take the next cervical cancer session. just to, sort of continue the narrative about cervical cancer. And we're going to be having Dr. Chiriki Kiredi from India taking that session for us. I believe she's here or he's here.
Yeah, I'm here. Can you hear me?
Yes, thank you very much. We can hear you.
Can you see my screen?
Yes, we can.
Video on చేయట్లా చేయాలా? Hello, good evening, good morning to everyone who are there. Today we are going to present on upcoming studies in hypofractionation in cervical cancer. Can you hear me?
Yes, we can. Hello.
We know, as we know, globally, cervical cancer among women is the fourth most common cancer, and it's the fourth most common cancer related mortality. So, but in low human development index countries, 84% of the incidents and 88% of the deaths are because of locally advanced cervical cancer. So we need to optimally utilize the resources. So this is one of the studies from European group, Embrace 1, where they have given EBRT 45 to 50 gray in 25 fractions in 5 weeks, along with concurrent chemo, followed by brachytherapy, which is MR based. And they have reported a local control, 5-year local control rate of 92% with acceptable morbidity. So when we see the brachytherapy schedules, the 2D to 3D era, if we give brachytherapy with MR-based HRCTV volumes, the local control rates are very high, especially for locally advanced cervical cancer. So now, as we know, the standard of treatment for locally advanced cervical cancer is 5 weeks of radiation therapy, along with 5 cycles of concurrent chemotherapy with cisplatin, along with 2 to 4 fractions of 4 fractions of brachytherapy in 2 to 4 applications. So best case scenario, the overall treatment time is more or less 6 to 7 weeks, and real world it may be up to 8 to 9 weeks. So according to the Retro Embrace and Embrace 2 study, each week delay beyond 7 weeks, this needs to be compensated by equity of 5 gray to HRCTV to achieve the reported local control rates of more than 90%. So this is the Retro Embrace and Embrace 2 study. OTT shortening, overall treatment time shortening by 1 week was equivalent to escalating a high risk CTV dose by 5 gray, resulting in increase in local control of 1% for low volume disease and 2.5% for high volume disease. So if the treatment time is longer or shorter than 7 weeks, then the dose planning aims should be adjusted by 5 gray per week for high risk CTV. Especially the OTT should be as short as possible for large size tumors where higher doses are needed to reach greater than 90% local control rates. So keeping in this mind, to reduce the overall treatment time, there is a study from Tata Memorial Center, Mumbai. This is the phase 2 interventional study, which evaluated the feasibility and safety to deliver the brachytherapy in single applications with multiple fractions, achieving an EQD2 of more than 84 gray to HRCTV. 3 fractions of brachytherapy were delivered over 2 days with a single application. Day 1, MR was done, 9 gray was given to HRCTV. Day 2, CT was done to see whether the applicator was in the same position or not, and 7 gray at 6 hours apart was given on day 2. And at a median follow-up of 22 months, they reported a dosimetric feasibility of 95% and local control rates of 90%, but the long-term outcomes are awaited. So now, according to this SIMRACE protocol, 5 weeks of radiation, 5 cycles of concurrent cisplatin, and single application of brachytherapy. So the overall treatment time has been reduced from 6 to 7 weeks to 5 to 6 weeks. So would it be possible to reduce the overall treatment time further? Whether this 5 weeks of radiation can be hypofractionated. Based on this, would it be possible to deliver that 45 gray in 15 fractions instead of 25 fractions? In combination with this single application brachytherapy, there is an ongoing study at Homi Bhabha Cancer Hospital, Vizag, which is a SIMRACE 2 study, which is a single arm study. And the schema goes on. EBRT was delivered in 3 weeks along with concurrent cisplatin, and there is a single application of brachytherapy. And the overall treatment time, as you can see, is reduced from 6 to 7 weeks to 4 to 5 weeks. So what will happen if you reduce the overall treatment time? So you can, if you estimate the alpha beta ratio of tumor as 10 and delayed OR as 3, you can see the gain of 4 gray in hypofractionated arm, but there is a loss of nearly 10 gray per OR toxicity, which after ignoring the impact of reduction in overall treatment time. So whether this loss of therapeutic index with hypofractionation can be leveraged with advanced technology, we're using image guided IMRT. So this hypothesis assumes that we can achieve similar pelvic control rates without significant increase in late toxicities, where the anticipated grade 3 toxicity should not be more than 5% as compared to EMBRACE 1 data. So these are other studies which are ongoing studies evaluating the hypofractionation for cervical cancer. This is a Mexican study, which is a phase 2 randomized control trial, where they are comparing 37.5 gray in 15 fractions versus 45 gray in 25 fractions. But the brachytherapy arm was standard, and the primary outcome was acute and late toxicity. There is another ongoing study, which is Heroic trial, which is a Canadian study. This is also a phase 2 study, which is a randomized control study comparing 40 gray in 15 fractions with 45 gray in 25 fractions. Again, the brachytherapy arm is standard arm. Their primary outcome was to see the feasibility. So in summary, hypofractionation for cervical cancer is experimental. Potential benefits include better compliance, logistics, cost effectiveness. There might be an improved outcome through reduction of overall treatment time. There are several ongoing studies evaluating the feasibility of reducing overall treatment time without increasing the late toxicities. But again, the goal of reduction of overall treatment time without compromising on late toxicities can be achieved by using of IGI-MRT and IGAB. Thank you.
Thank you very much. Again, these are very interesting conversations, and there are interesting conversations going on in the chat at the same time as well. Dr. Umesh, I see your hand. If you don't mind, could you post in the chat for now? And then when we get to the panel, we'll have all the discussions. I think we have to, Dr. Avery, are you ready for us now?
Yeah, did you receive my slides?
Yes, I'm checking again now.
I also sent them to the secretary and to the admin too. I'm not sure. I can try to share again. I think it may just be the connection here. I'm sharing now. I don't know if you see the screen or not.
Yeah, your connection sounds better now. So you might, yeah. But I unfortunately I still don't see the slides in my email. Oh, there you go. We can see your screen now.
Okay.
Okay, so thank you.
So that should start before the connection was there. All right. So yeah, so I want to talk a little bit about we've been talking about hypofractionation and so a little bit about the requirement. Now, I know this is supposed to be like a 10-minute talk, and I can't really do it justice in 10 minutes, but I'll kind of follow some things that Professor Ngoma mentioned, but also give you some areas where there more information that you can have access to. So just some basic definitions on like what is hypofractionation, because we're talking about it just so people may be at different levels of it. So I just want to make sure that we're all on the same page. So this is just for typical prostate cancer, conventional therapy, maybe over 8 weeks, where we deliver about 200 centigrade per fraction, 800 to 200. Moderate hypofractionation is really cutting that down almost in half to about 5 weeks, where we increase the dose, about 240 to 340 centigrade. And then ultra hypofractionation is where we have up to 500 centigrade or more, and this is in 1 to 2 weeks. So, so when we talk about is really just shortening the time, increasing the dose. A lot of things that we do now, we continue to do, but it's more important that we really understand the quality assurance, because it's not as forgiving as in conventional therapy, where you have more time, and if they miss a couple fractions, you might be able to make it up. With hypofractionation, you may not have that advantage anymore. And so it's really important to have your quality assurance really up to date, and you are really aware of your program. So just a little bit of background. We did have a course last year about hypofractionation for different sites, and different universities did participate. And so we did record these sessions. And so I'm going to see if we can make these available. And I will send information to the aortic secretary for people who are on this call, because like I said, this is a very important topic, and I think in the time we have, it really just begins to really touch on it. But there's information out there, and I think that I will try to disseminate this information to people who are on this webinar also. So Professor Ngoma did talk about Hypo Africa, and so I don't need to go through all the details that he mentioned. I will kind of focus on this last bullet point here, is that we did conduct a survey on clinics that were looking at hypofractionation, and just to discuss a little bit what are some of the challenges that that they may be facing. Again, this isn't anything new that you're already doing in the clinic. Is really, how can we make sure that our quality assurance is up to date, and that we are, aware, and that the maintenance of the machines are up to date. So from the survey, there were 3 main challenges that came out about implementing hypofractionation in sub-Saharan Africa. The first was the machine and patient quality QA.
Oh no, I think Stephen, we lost you if you can still hear me. Can you hear me, Stephen? Are you there? Stephen, we can't hear you. Can anyone else hear Dr. Avery? Oh,
No,
I don't.
I can just see his slides.
I don't think he knows we can't hear him. Let me see if I can call him.
Okay, here we go. I was muted. I did unmute myself. So.
Okay.
Yeah, I think I was kicked off, and now I'm back. I'm back again. So can you hear me? Okay. Can you hear me? It says I'm sharing my screen. Okay, great. All right. So like I mentioned, the 3 challenges. One was the machine and patient QA. So again, we're not doing anything different. The different groups that we talked with were the East, West, and South, and different locations had different ways of doing patient QA. Some places would use film, some places would use EPIC, or some places would use like a flat panel detector. And so really we reviewed the QA protocol just to make sure that there wasn't anything that was missing. And so that's very important, just to look at your protocol to know how do you identify any issues. Is there anything that you can improve? And so that's one area that we have been working with different locations to discuss that. And again, everyone does QA different. Not everyone does it the same, but however you do it, you want to make sure that the protocol is sound and very robust. The data and quality harmonization. Professor did mention about the patients that we have, and And hopefully I stayed on. I'm getting a message saying my connection is unstable. But I think I'm still here, everyone.
Yeah, we can still hear you. Thank you.
I get a replay. Okay. Okay, I just try to get kicked off again. And also the machine maintenance. Again, these are issues that we already are dealing with in sub-Saharan Africa, but they are even more important when we talk about hypofractionation because of that we are decreasing the number of fractions. And so I think we really need to try to really address these issues if you're on the program. Some other solutions that we discussed were doing it in remote audit. Typically, an audit around like a phantom or something, you can erase it, send it back, analyze it. But
we've lost you again.
all right, I'm back again. I don't know why it keeps kicking me off, but I'll just keep reconnecting and just pick up where I left off. So for the audit, it gives it the ability for you to send your information directly from your machine to verify those, to verify your plans, to make sure that what you're doing, because for your clinical trial has met the standards. Because if you're implementing your hypofractionation program, and then initially it will be a clinical trial. Another method that we were looking at too is a way to monitor the machine remotely. In different places have different QA programs, but you will make sure that you can see if the machine output is changing, if it's drifting day to day, and if you need to readjust. And I think this is important because we do see that there are different levels of human resources. Places have maybe more or less physicists, and sometimes all right, well, yeah, we'll just keep doing this until I get through. So, sorry. So I mentioned that being able to really keep close attention of your machine, and if it is changing, then when you readjust. And I think this is another way where you can have other partners maybe assist in that. And also there's the train the trainer idea, where as hypofractionation becomes, as we implement it in more and more places, there are additional learning that needs to happen. And so I think that's a big component. The longer term solutions will be building up the workforce, having maybe some telehealth options where we can do QA, some peer review, and some support. So ultimately creating some type of a center in Africa where we can manage these clinical trials as we implement other things that are going to come after this hypofractionation. So we have published a paper recently which talks about some of the challenges that we've talked about and Professor Ngoma mentioned. And I think that it can expand again beyond what we're talking about here. But I encourage people to look at this publication, which some detail about implementing hypofractionation in Africa and the lessons that we've learned from the clinical trial. So with that, I apologize for the technical difficulties that we had, and I will participate in the panel discussion for further discussion. Thank you.
She's talking to Kim, but
So thank you very much, Dr. Avery. I was really desperate for the physics session because if anyone is like me, physics is a struggle in radiation oncology for me anyway. I just want to say thank you again to all our speakers. The sessions have been very interesting. I can see a lot of people who are very eager to have a serious discussion about the things that we've talked about today. And with that, I'm going to just move it along for us to go to the panel session. So if we can have all of our speakers just sort of ready to take questions, I will try to
have her hand up. I don't know if she had a question. I see Verna's hands up.
Yes, so I will try to field and direct the questions. If you can post in the chat, that'll be wonderful. Dr. Umesh had his hand up first. So if it's all right with you, Dr. Verna, can we take him first and then we'll come to you? And then we'll go through all the questions in order. Thank you so much. So Dr. Umesh, if you want to go, can you unmute yourself, or do we have to unmute you?
Okay, they're able to unmute themselves.
Okay.
Hello, good evening.
Good evening. Thank you,
Can
Dr.
you hear
Umesh.
me?
Yes, we can hear you.
Yeah, so I just wanted to make a few general remarks that the protocol which was published called as SIMRACE 1, it was done as a scientific study even before the COVID pandemic started. So it was not by virtue of having an alternative option during COVID pandemic, but this was more of a scientific question which we are asked in this single application and 3 fractions treatment, because it is quite relevant to most of the world, number one. Number two, the study was done in a very, very, very strict environment of image-guided adaptive brachytherapy, because we wanted to really see how it works. And of course, the results are shown as early results. But my take on this is definitely with newer technology, I think we will have more and more such schedules being explored and researched. And I think it is very relevant research for most part of the world for cervical cancer treatment. Thank you.
Okay, so thank you very much for that context, Dr. Umesh, and you're absolutely correct. Single application would definitely be a huge improvement in our current model. The model of multiple insertions and applications is certainly a burden, and I think most people would agree, whether high or low income. So I think that's a very interesting conversation that we do need to have. And we're going to take Dr. Werner now, and then we'll go to the panel session. Thank you.
My only question is that I see a lot of QA supervised from outside. I think we should start developing our internal systems so that we can do our own QAs. That's how to build up, a health system. So we don't have to depend always on people. We learn from them, but I think we need to strengthen our own systems because we know our problems better. You understand? Yes. So I think we need to, whoever is doing these studies, I think inwardly you need to develop your systems. And I think that's the beauty of this hypofractionation. I'm actually very excited about it because it gets people to understand why we need Q&A and all that. Before it was like people didn't understand why the doctor was fussing, but telling us how to do things. So I think we need to develop our own internal systems and strengthen them, based on what we have and the way we do things. I think it's very important. Thank you.
Yeah, I totally agree. Sorry, Eddie. I totally agree, Vernon. I think that's one of the points I put it was train a trainer, is that we just are, we're working with different centers and helping them, develop their QC program. And actually, one of the physicists from Ocean Road has a poster that he's presenting at AAPM for his work, and so I think, yeah, that's the, one of the main goals that I think that we have to, make that a priority. I agree.
So I was just going to say exactly what you said. While we're doing the Q&A, it's more of a capacity building program in that all of the centers are learning from the process. And I mean, at this point, the physics team has been having weekly lectures for several weeks now. Every aspect of the team really is building capacity as we go along. So it's not really just being entirely done for the team as opposed to, building capacity to make sure you can do it by yourself. I think Prof Twali wanted to contribute to the conversation. And Prof, unfortunately, we lost you at the end of your presentation.
Yeah, it's okay. I wanted to tell Werner that one of the things we want to achieve in this hypo trial is to have imaging radiation oncology core and have more centers in Africa join this team. And it's through this IROC Africa that quality control issues will be developed and adopted throughout the continent. Yeah.
Thank
you very much.
Finished.
Okay, so we're going to start the Q&A now. I think we received the highest number of questions with the breast session. And I copied them out and we'll read them out. But I think that all of our panelists can take any question, and please just unmute yourself and volunteer to take an answer. So I'm going to start with the first one, which said, thanks for the presentation. 2 questions I want to know: why the arm of 27 in 5 was associated with more acute and late toxicity as opposed to the 26 fraction? And yes, that's a very interesting question. The question is that, and for those who missed the breast session, it was a review of the fast forward trials, fast forward and the START trials. And, just reviewing the findings between the 26 in 5 and 27 in 5 arms and the significant difference in toxicity. And just, curious as to how 1 grade difference per fraction can make that much of an impact. So Dr. Adoko Ayiti, do you want to take that? Dr. Nadoko, sorry, do you want to take that?
Yeah, so I can attempt to answer that. In the, the dose levels for the fast forward trials, they were from the START B, that's the 40 grain 15 fractions. And then the 27 grain 5 fractions is from the fast trial. The other arms in the fast trial were 30 grain 5 fractions, and I think 50 grain 25 fractions. However, in the fast trial, the doses were given weekly, once a week, over 5 weeks. What that did was that it allowed time for the late responding tissue, so the normal tissues, to recover, and so to have fewer late toxicities. And so as part of the fast forward trial, an analysis was made and determined that reducing the dose from 27 in 5 to 26 in 5 would take care of the time factor, the extra days that are required for normal tissue toxicity to recover. And so that's the reason for the 28 in 5. As for details about why it's so significant, it's really because of the dose response curve. Like I said, the dose response curve for normal tissue toxicity, normal tissue effect, is very steep. So any change in the dose will result in a significant amount of toxicity, whilst that for subclinical diseases is really shallow. And so the outcomes were the same for inverse tumor relapse rate.
Okay, thank you. I think that's a very good explanation. And, just going on from that, it then says, I think the next question has been answered, which said, why were 2 hyperfractionated arms used rather than 1 arm comparing with 40 gray? So I think that question has been answered. The next question says, were surgical clips required for all patients? What are the additional steps required for hyperfractionation in treatment planning beyond conventional fractionation? I think the question about surgical clips is important because, again, in our environment, you won't always have that. So if it becomes something that's necessary, and I don't think it is, it would impact the ability, the feasibility of application. But anyone of the panelists can take that.
Okay, so I'll just make a comment that for the patients who had breast conserving surgery in the fast forward trial, at least the surgeons were encouraged to use clips for the surgical bed, obviously if you needed to boost. But I didn't get the indication that all the patients had the clips in the tumor bed. If it's there, it's very useful. If it's not, I think you can still treat the patient. In the fast forward trial, they used electronic portal imaging devices. And for the patients who had the 5 fractions, they needed daily verification. And there was no allowance for deviations. So any deviation needed to be corrected. However, in the 40 grain 15 fraction group, I think in the first week, you needed to do 3 verifications, and after that, it was weekly. And there was an allowance for a 5 millimeter deviation. So I guess there are things that you need to be wary of. If you have the clips, perfect. If you don't, you can still do it, but know that you need more verification to ensure that your treatment is going where you want it to go to.
Thank you. And then the next question says, is it applicable for whole breast irradiation? Which the answer is yes. There were whole breast and post-mastectomy patients treated on the trials. And the next question after that is, when regional node irradiation is indicated, we can no longer use 26 gray. In Africa, more patients present with locally advanced disease. So the essence of this question is, can you do nodal irradiation with these hypofractionated regimens? And again, that impacts the feasibility because many of our patients will need to have the nodes irradiated.
Yes, doctor, I actually did make a comment on that. There's a sub-study which started while the fast forward trial was going on. And that allowed for the same hypofractionation doses to be used for patients who had done sentinel lymph node biopsy and no further surgery, and so required axillary radiotherapy and supraclavian radiotherapy. And also for patients who needed supraclavian radiotherapy only after lymph node dissection. So we'll wait for the results of that sub-study, but it appears as though it is equally effective with the same risk of normal tissue effects.
Okay, so thank you. I think we've answered most of the questions from the breast session. The next question now is for prostate to say, okay, so the first question was about what are the parameters required for quality assurance in radiotherapy? I don't know if there's a brief answer to that, but Dr. Avery, do you want to attempt to summarize that for us?
So you said the question was what the requirements?
Yes, what are the parameters required for quality assurance in radiotherapy? That's a very good question.
Yeah, like I mentioned, I think that what we're doing now, even for hyperfractionation, is it's not that we're doing something different for quality assurance. It's just that we have to really pay more attention to it because the time is shorter, the dose is higher. So we're not doing a new method for QA. We're doing the same methods that we've done before. And so I think as far as the requirements are the same requirements you have in your clinic now. We review the protocols of the different sites that are part of the Hypo Africa clinical trial, just to make sure is there any way that we can improve it or add on it or anything that's missing, but there's nothing new or different. I think it's really just to make sure that you are maintaining your quality assurance program and that you have reviewed it and that you're also following it. And if there are questions, that you have about it, that you are reaching out to people to update it. So I guess that would be, and one thing I did want to add that I guess we haven't brought up is, we've talked about the physicians and the physicists, but we have to think about the therapists also, because the therapists are the ones setting up the patient every day for hypofractionation, and localization is very important too. So that's another point that I think we should raise on as you implement this into your clinic.
Okay, thank you. The next question was also from the prostate session, and I think Prof. Ngoma would be in a good position to take that, or I can take it. It says, so how do you select patients to receive pelvic irradiation versus not? Your protocol includes patients with any T and low risk. How much dose per fraction and total dose do you deliver to the pelvic lymph nodes for high risk patients? So Prof. Ngoma, do you want to speak to that?
Yes. Yeah. In our protocol for high-risk patients, we give them 62 gray instead of 60, a bit higher than the low and intermediate risk. And as again, we were looking at localized prostate cancer. And in planning, we made sure we included the whole prostate, seminovesicles. And if there were any high-risk factors, then the dose would be a bit higher because of that.
Thank you. Again, so the thing to remember is that what we're doing is really studying the feasibility of implementation. We're not, this regimen is not something that's new. If you look in the NCCN guidelines, it's actually standard of care now. So it's not particularly a brand new regimen. We're just really trying to demonstrate that it can be safely and effectively and reproducibly, practiced on the African continent. And also to then document the results. As we know, African prostate cancer can be different. So we want to document and see that we have the same results as when it is applied elsewhere. I think if I haven't answered your question, do you mind raising your hand? Because I think I've tried to cover all of it. Okay, Dr. Umesh has his hand. Dr. Umesh, please go ahead and speak.
Yeah, just to add to the previous question of high-risk patients being radiated for pelvic node, we have been practicing moderate hypofractionation of 60 gray in 20 fractions to the prostate and seminal vesicle, and pelvic nodes get roughly around 45 gray in 20 fractions. So that is equivalent to somewhere around 50 gray. So by delivering 50 gray to pelvic node in a prophylactic setting, this works very well in our setting. Thank you.
Yes, and I do know that that's also being done in Nigeria as well. So thank you for adding that, Dr. Umesh. Are there any more questions? And if they're not, we can, attempt to wrap up. So any question that hasn't been addressed, answered, any comments that anyone wants to add to the conversation? I don't see any. And so with that, I want to say thank you to everybody. Thank you especially to our speakers for taking time out of your very, very busy schedules to, be able to teach us today. Thank you to everyone who attended. On behalf, again, of the chair of the Special Interest Group, Dr. Hannah Simmons, I want to say thank you. And just before we wrap up, if you don't mind turning on your camera so we can just take a quick photo and then we'll say our goodbye. Thank you to everyone. The presentations have been excellent. The conversation has been stimulating. We're very happy to put on here. photo, please. Thank you, everyone, for participating. Cameras on, please. People. Cameras.
I'm not able to. Host has disabled the camera.
So my light isn't great, so I'm not sure how well my picture will come out, but my camera's on.
Oh, we can see enough of you.
Thank you, everybody. And we continue the conversation in the car, hopefully.
But Mira, it says cameras are disabled, so.
Oh, okay, don't worry. It's fine. Okay, don't worry. Thank you very much.
Thank you. Bye-bye.
Thank you, everyone. For
I can turn on my
participating.
own camera.
I really appreciate it.
It's okay.
Yeah, that's
Thank you,
okay.
everybody. Bye-bye.
That's something we can fix. I don't think so.
No, I'd
Unfortunately.
have to go to everybody and do it individually. Yeah, it's restricted, unfortunately.
Okay, bye.
We'll continue in the car.
Yes.
Thank you so much,
Bye.
everybody. Bye.
Goodbye, everyone.
Belle, can you stay on a moment?
Bye-bye,
Sure.
everyone. Thank you. Thank
That
you.
was amazing. Thank you so much.
It was
Thank you.
fantastic. It was
Thank you so
fantastic.
much. That was amazing. Yeah.
Thank you,
Yeah,
Radiation
thank you.
Oncology Special Interest Group. Thank you very much.
Thank you
Thanks.
for having me.
I hope we have a nice meeting in Senegal. I hope all of you come.
Of course.
To Senegal.
Yes, this
Of
is a
course.
taste of what is going to happen. This is just a taste of what
Yes,
is
Dr.
going to happen
Vanderpoy.
in Dakar.
This is a starter. A starter.
Yeah, it's starter. Yeah.
The main course is going to be in Dakar.
Yeah.
Exactly, I like that.
Anna, I'm going to call you in 2 minutes.
Okay, I'm still here with Belle, so maybe
I should join? Okay, I'll join.
you can join. Yes.
All right. Hello. Yeah.
Okay then. Bye-bye.
Bye,
Bye.
President.
Bye.
Bye. Bye.
Bomira, do you want me to stay on or?
It's not necessary. We are just going to talk about a few program issues for AOT 2023 with
Okay.
Anna. Yeah. But thank you. Wonderful job. Thank you, Joseph. It was very good. It was
you.
a day. It was lovely.
Really enjoy this moment.
I
And
did
I really enjoy
excellent.
this. I really appreciate it. It's so educating. I'm Gimba Zafania Arense
Yeah,
from
very, very
Birmingham
educated.
University.
Yeah.
Yes, Department of Radiography. So I find it very, very interesting and knowledgeable. Thank you.
Fantastic.
For the
Thank you for
organizer.
joining.
Yes, thank you.
Sorry.
Thank you. Thank you. Bye.
Bye-bye, everybody.
Bye. Thank you. Yeah.
Thank you. See you in the car.
Hi, Hannah.
Yeah.
There's still quite a number of people on.
Why I can't do a video? You want to see my beautiful face?
That's one up. Hold on a bit. It's so happy.
You should be able to do it now.
Hello.
Bye, Anne. Bye, dear Vita.
It still says no.
I'll let it. It should be on now. There was a bit of a
Okay.
delay.
There
Yeah.
are too many faces.
We still have a lot of people on.
Oh, I can pick them or check them
Yes.
out. Okay, I see what you mean.
Yeah.
You see
Bye,
why
Anne.
we need oh, India, all of that. Coast. Our
Yeah.
bosses. Oh my God, I'm yawning. I forgot I was on. And I was yawning. I don't think they know they're on, you know.
Is it? I don't know if I can.
Once you go off, then we'll all have
remove.
to
I will
join again.
remove. I will remove.
Oh, okay, you can do that.
Has anybody asked about
One moment. Let me
our
just
colleagues in
remove.
Sudan? Has anybody heard from them? Our
Sorry,
colleagues in Sudan.
I'm just busy removing people.
Okay.
So I called briefly concerning the Dr. Fojo. That's okay. So it's not possible to get him to send it by mail or something.
Almost done.
Discussion. Maybe we should next meeting. Whether we should do it out of the doctors who want to volunteer or something like that.
There are only a few more.
Yeah.
Have a nice holiday.
So now what did you say about it? It's not here. No, she's gone. Okay. Yeah.
I'm still
One more.
doing.
Yeah.
I'm still doing. I'm still doing.
We just have, yeah, one more, then
I
4 of
can't-
us.
So you can remove
Get
the
it,
recording too.
I don't know why I can't get it off.